Am I audible? Can anyone please tell me? Am I audible? Okay, thank you. Okay. Before we are going to start anything further, can we all have a moment of silence for to acknowledge for the tragic loss of few Indians who lost their lives in recent Pahalgam terrorist attack, please? Thank you so much for your patience, all of you. Good afternoon, doctors gathered here. As the summer has begun, and most of you might be experiencing the influx of periodontic patients. So this time is an ideal time to focus on our enhancement of knowledge regarding recognizing and correcting developing malocclusion in children, right? So let's dive into the world of periodontics to explore the new insights and latest techniques to provide the best care to our younger patients. Before that, let us welcome our speaker of the day, our guest speaker, Dr. Ravi sir. Good afternoon, Ravi sir. Oral Jnanadhare is happy to have you here as a guest speaker. We all welcome you, sir. Let me give a brief introduction about our guest speaker. Dr. Ravi sir has completed his graduation from JSS Dental College, Mysore, and master's from Bapuji Dental College, Davangere, in the department Periodontics and Preventive Dentistry. And he has more than a decade of experience in the field of periodontics, academics, and treating the little ones. Also, currently, he is an associate professor in the Department of Periodontics at Kelly Dental College, Bangalore. And sir consults various dental clinics across Bangalore as a specialist. Ravi sir is a doctorpreneur, owner of exclusive pediatric dental care named as Kirunage Dental Care at Dasaralle, Bangalore. Apart from this, Ravi sir is not only passionate about sharing his expertise and treating the pedo patients, but he is also a renowned badminton champion and winner of numerous medals. Many of us know that. Very nice to know that, sir, and inspiring also. Once again, we welcome you, sir. Floor is yours. Please give me a second, participants.
Thank you, Bharti. Thank you for the good introduction. Am I audible?
Yes, sir.
Okay. Can you enable my screen sharing? It's disabled.
Give me a second, sir.
Yeah.
Yes, sir, please go ahead.
Yeah. Can you all see the screens?
Yes, sir.
Good afternoon, everyone. Yeah, myself, Dr. Ravi Kumar. I'm a pediatric dentist. I've been exclusively practicing pediatric and preventive dentistry for more than a decade now. And as far as my experience goes, the branch of periodontics is one of the most hated ones in the general practice. That is because of the time that it consumes and because of the uh, uncooperative patients. So it's not so well practiced. And today we are here where I share my experience in recognizing and correcting developing malocclusions. I'll be sharing all the essential knowledge, and it won't be a, theory. Moreover, it will be more of a practical knowledge which I have seen throughout my pediatric practice in the past decade. If you have any doubts, you can just put it in the chat box. I'll go through it in the end and I will try to clear all your doubts in the end. So let's begin with the objective of my presentation today to you is to make you recognize a developing malocclusion, to know the causes of a malocclusion, to recognize it before it even it happens in the oral cavity, and in the end you should decide whether this malocclusion can be corrected by yourself, or it should be referred to a pediatric dentist, or it should be referred to a orthodontist, or it is a teamwork. Okay, recognizing it and just ignoring it, so that telling the patient that it can be corrected after 13 years of age. The most commonly used sentences by general practitioners in treating malocclusions is it all can be corrected after the age of 13 years. We can wait until then. So that's a false thing to do, according to me, because recognizing it at the earliest stage can help immensely the musculature, the oral cavity, the alveolus, and the teeth to well align in the arch and establish a equilibrium between the extra and the intraoral muscles and the maxillary and the mandibular arch. If it is recognized early, it can lead to a normal growth and it reduces the complexity of the secondary orthodontic treatment at a later point of time. So, correcting it and intercepting it at an earlier age will reduce the severity of the malocclusion at a later point of time, and it will be easy for the orthodontist to give a good occlusion or a arch patterns in the end. So our goal is to establish a stable, functional, and aesthetically acceptable occlusion. And this is an integral part of our comprehensive oral health care, irrespective of the age. So early diagnosis and successful treatment plan to treat the developing malocclusion establishes an occlusal harmony and a good function and gives the patient a good dentofacial aesthetics. So our job is to recognize, diagnose, and manage or refer the abnormalities in the developing period itself. If you are not able to recognize and diagnose, you will not be able to manage it. So we will share most common conditions seen during the primary dentition and in the mixed dentitions, where you can easily know what it is and you can know whether you can treat it or a referral is needed to the pediatric dentist or a fellow orthodontist. So orthodontic treatment is rarely done in the primary dentition. So you don't see any fixed orthodontics in the primary dentition because more forces on these incisors and the canines can lead to accelerated root resorption and premature loss of the primary tooth. And any movement of these primary teeth has little effect on the permanent teeth where it erupts, and growth modification effects in very young children are lost to a resumption of the growth in the original pattern. But it does not mean for us not to establish an equilibrium between the intraoral and the extraoral muscles. Any malocclusion that is developing or which is seen is always due to the disturbance in the equilibrium of the dental arches. The extraoral and the perioral musculature and the tongue, which is the lone intraoral muscle, always helps to keep the arches in equilibrium and to align themselves. Any changes in these forces or the equilibrium will tend to derail the normal occlusion or the growth of the maxilla or the mandible. So our goal is to identify them at the earliest phase and to treat it. So let's begin with the primary dentition period. The diagnosis or prevention of malocclusion doesn't begin when you actually see the malocclusion, but it begins the day the teeth erupts in the oral cavity. That is around 6 months to 7 months. Why I am telling this? Because in the initial years, the first year and the second year is where the dental or the oral hygiene is neglected the most, and the maximum of the destruction happens during this period itself. By 2 years of age, the individual would have lost all the central incisors and the lateral incisors, and most of the first primary molars and the canine would have been lost to dental caries. Early loss of these teeth will lead to development of aberrant habits, will lead to perioral infections, will lead to dentalveolar abscess, disturbs the developing central incisors or the lateral incisors and the premolars, alters their morphology, disturbs the position of the developing tooth birth. All these factors leads to a developing malocclusion at a later point of time. Hence, for me, the first 2 years of life in the infancy is very, very important in preventing a developing malocclusion. It all begins with these white patches at the 9 to 10 months of life, because this is where the initiation happens. And the next phase, you can see a tooth that is totally lost with just root stumps left behind by 2 years of age. This is because you neglect to treat these patients at this very age, because the parents are also anxious to get treated at the very young age, because the patient is not so cooperative at all. The patient does not sit, the patient is totally uncooperative. So it becomes difficult for you to manage this patient. Hence, you tell it can be treated at a later point of time. The child is too young and you postpone the treatment to maybe another few years. By that time, you'll see the total destruction of the tooth itself. The total loss of the crowns in these anterior segments disturbs the position of the tongue itself. So, when the teeth erupts, the infantile swallowing should switch to a mature or an adult swallow. So, swallowing here should be restricted by the teeth present in the anterior region, but the absence tends to keep the tongue still in between the teeth and the infant tends to swallow. So, this alters the tongue musculature, it alters the arch form of the palate because the resting position of the tongue is changed because the adult swallow has not been established at all. So, by the end of 1.5 to 2 years, with the complete set of dentition erupting, the infant should switch to a normal swallowing pattern. With the normal swallowing pattern, this tongue rests in the vault of the palate. This resting position of the tongue in the vault helps in establishing this arch form. Failing to do so, lowering the position of the tongue, okay, lowering the position of this tongue helps the buccinator to put more amount of forces on the posterior teeth, constricting the arch, reducing the arch width, and making the palate vault too higher and a narrow palate. So here it starts, the malocclusion starts here itself at this very young age because the tooth have been lost to dental caries. And also, these infected anterior teeth are neglected. The pulpectomy is not being done, it has been postponed because there is no any symptoms. but this might lead to a periapical, chronic periapical infections where the permanent incisors are developing. Because of these infections, the tooth bud, the developing tooth bud, changes its normal path of eruption. Either it might go more palatal, or it might become horizontal, or it might go more distal because of the persisting infection in the periapical region. So this effect is not seen now, but when around 7 to 8 years the incisors tries to erupt, they would have already changed their path of eruption at the initial first 3 years itself. That is why you see in such cases these incisors will be over retained, and also the permanent incisors either they will be impacted or they will be erupting more distal or more commonly in the palatal aspect, with still these primary teeth over retained in the arch. This is because of the early infections in the dental alveolus persisting for many years, because they were left untreated, they were neglected at the initiation itself. So I insist you dental practitioners, if at all if you see a infant in the first year of life or in the second year of life, always do an examination to see these white flecks on the labial surface. Check about the dietary habit of the infant. These days, because of the working mothers, the baby is insecure and it's left with a caretaker. Hence, bottle feeding has become more common these days. With bottle feeding, the perioral muscles have very less work, and normal breastfeeding always activates these muscles, the elevator muscles of the maxilla, sorry, the mandible and the perioral musculature are full in effect during breastfeeding, but because of the working mother, the breastfeeding is stopped and the baby is switched on to a bottle feeding. And also, this bottle feeding is being continued even after the full dentition is present in the oral cavity because of some reasons. The infant has become totally dependent on bottle feeding, and every night when there is insecurity, the infant asks for bottle feeding. So throughout the night, the bottle has been fed, and in such cases, you see total destruction of the teeth, the anterior and the posterior teeth, totally destroyed by this bottle feeding. There is no crown structure at all by the end of 2 years, but still the baby is totally dependent on the bottle feeding because there is no tooth structure to chew. Weaning, the shift of the diet from a soft diet to a semi-solid to a totally solid diet, has not happened because the failure of these teeth to aid in chewing of the food has been lost because of the decay. And this decayed teeth leads to food lodgement, causing some troubles during the chewing, and patient wants bottle feeding more than shifting to chewing solid foods. And also this soft diet prevents chewing, hence these muscles, the perioral muscles, the elevator muscles of the mandible are weak, they are not strengthened by the chewing pattern at all. So here starts the problems of malocclusion due to the change in the equilibrium in and around the oral cavity. Hence, prevention at this stage is a must. And also, the proximal lesions in the posterior aspect lead to the mesial migration of the tooth, closing away the primate spaces and any other spaces that is being present in the arch, leading to a loss of arch length. By the age of 6 to 7 years, with the eruption of these permanent molars, totally these spaces are lost and occupied, and there is no more leeway space also left. This also increases the significant risk of malocclusion in the future. So, if at all, if you see a proximal lesion, it should be restored at the earliest, and the arch form of the tooth should be restored back. Failing to do so, this will destroy the whole tooth structure, and the erupting molar will move more mesial and mesial and take away the space of this grossly decayed primary molars, leading to a significant loss in the arch length. Loss in the arch length is very difficult to treat because you are supposed to distalize all the tooth to regain the space, or at the age of 13, 14, 15 years, the orthodontist chooses to extract the premolars to gain space. So extracting the premolar is not so easy because there are chances of relapse later during the treatment stages. So, preventing these at the earliest stages is a small step in preventing the developing malocclusion. Hence, during the first and second year of life, if at all if you're seeing early childhood caries in these infants, prevention has to be initiated. This prevention at this age is very, very, very simple, and you're going to restore the lost minerals from the tooth structure. My favorite at this age is a fluoride varnish or a GCMI paste plus, that is your CPP ACP paste, which is a very good remineralizing agents. This fluid protector has to be applied onto the tooth surface on the whole arch. It's not to be applied on the carious tooth, but on the tooth which has just lost its minerals. The white spot lesions has to be identified, and this fluoride varnish applied has to be applied onto the surface, irrespective of the age, whether it be first year, 1.5 years, 2 years, 2.5 years. Any tooth structure that has lost its minerals, you are going to bring it back to a normal pattern by applying this fluid protector. So this has shown immense results. Success rate is very, very high in bringing back normal enamel surface to the tooth. And also for home care, you can prescribe either the CPPSP paste, which has to be applied onto the tooth surface just for 4 minutes in a day, or it can be used as a toothpaste also. Along with you have Clean Pro tooth cream. All these are non-fluoride remineralizing agents, and also you have professionally applied fluid protector. So this is a very, very, very simple treatment you can do at your own practice, but you are supposed to identify, you are supposed to tell the patients the consequence of not treating these incisors and the canines or the molars at this very early age. The problem treating these infants is the denial by the parents that the patient is totally uncooperative, and it's not good for the patients to undergo dental treatment at this very young age. They avoid dental treatment and they do not insist restorations or pulpectomies. So preventive services should always be insisted at the earliest. You should show the consequences, what might happen if this is left for another few years. Within 1 or 2 years, the total posterior teeth will be lost to dental decay. That leads to a loss in the vertical dimension only. That leads to increase in the deep bite. Eruption of the posterior teeth should decrease the deep bite, whereas the total gross decay of the posterior teeth will increase the severity of the deep bite, and it doesn't get auto-corrected. This deep bite was a self-correcting malocclusion in the primary dentition, but with the gross decay tooth, it is no more a self-correcting anomaly. And if at all, if there is a dental caries already, you cannot prevent it, but the child is totally uncooperative for you to do a restorative treatment. There is one material known as silver diamine fluoride, a boon to us. Okay, it's a very good material that is to be applied onto the carious lesions only, not to the tooth surfaces, only to the carious lesions. Okay, the silver and the fluoride reacts with the carious dentine, and it forms a black discolored dentine. This black discolored dentin arrests the caries immediately. So this material, the SDF, is a temporary measure and it's not a final treatment for the tooth. This material I use only to postpone the treatment for a duration of around 6 months, because the patient is totally uncooperative and the parents are not ready for any sedation or any other procedures to be done because of the uncooperative nature. So I choose this SDF. This is just to be applied on to the carious tooth structure with a brush, and immediately you see the color change. You see the color change of the dentin to a pitch black. That arrests the lesions. It doesn't progress to involve the pulp, and this SDF should not be applied onto the exposed pulp or a painful tooth. This should be applied only to an asymptomatic tooth only, never to be applied on a pulp or a painful tooth. So it has shown wonderful results in controlling the caries lesions. If left because of the uncooperative nature of the patient, within a year you will see no tooth structure at all in the entire anteriors, and you will see total root stumps along the gingival line. So that's a disaster because you just postponed it because you had no choice. This can be done by anyone, and you can easily convince the patient because the benefits of this is too much, and it has shown successful results. I have done it multiple times when I myself am not able to uh, treat very young children because they are totally uncooperative and the parents are unwilling to do so. So for a duration of 6 months, I postpone it. I recall the patient. If the patient is cooperative, I carry out the restorative treatment. So this was one case which I saw recently. It was a patient who was aged 1 year, and there was no history of bottle feeding, sole breastfed infant, but you can see both the incisors totally destroyed because of the early childhood caries, because of breastfeeding, and the mother did not clean the surface of the enamel after breastfeeding. So this dark lesion what you see is because of the application of the SDF. I applied SDF because the patient was too young, the patient was totally uncooperative, and the parents were not willing. So I said about the silver diamond fluoride and its benefits, and the patient totally agreed. I've applied silver diamond fluoride just for now. It will arrest the spread of the lesion. I recall the patients after 3 months to see the progress, and I have told them home care for these erupting tooth and the other erupting tooth, and to avoid breastfeed at will, and also to introduce solid food, semi-solid food, along with limiting the breastfeeding because the infant has already crossed 12 months. And this is one case published where you see the posterior teeth also is being applied with silver diamond fluoride. I do apply this silver diamond fluoride for the posterior tooth too, where the patient is totally uncooperative and it's impossible to treat on the dental chair. So application of this to the dentine, caries dentine turns the tooth into pitch black, but the benefit is that the caries is arrested immediately and it doesn't progress. I recall the patient after a few months, check for the cooperation. If the patient is cooperative, if I can manage, I'll just go ahead with restoration of these lesions. So these are few simple things which you can do at the very, very, very first and second year of life. This is an important age period where the oral hygiene is neglected to the maximum, and most of the patients do visit us at 4 years, 5 years, 6 years when there is severe pain, swelling, abscess, base infections, and it's very hard to treat at that stage. So prevention of malocclusion begins in the very first year of life. And during the primary dentition period, there are various oral habits that develop. And the most common one is the non-nutritive sucking habit, that's your thumb sucking or the digit sucking, because urge to sucking is something normal for the first 4 years of life, and it might persist over a period of time to cause certain malocclusions, mainly the anterior open bite and the posterior cross bite. And also tongue thrusting habits due to any underlying causes might also lead to anterior open bites, abnormal speech, and also protrusion of the maxillary incisors. And mouth breathing due to any trouble in the nasal cavity because of any tumors or deviation of the nasal septum or any allergies or any asthma. The patient tends to breathe through the mouth, and also this leads to increase in the facial height at dolichocephalic face, anterior open bite, the mouth apart always, and increased overjet spacing in the anterior teeth, and also a narrow palate. And also obstructive sleep apnea, quite rare, but still it causes certain malocclusions like narrow maxilla, crossbite, low tongue position, hampered vertical growth, increased overjet, and open bite. So identifying these habits is a must, and you should know the intensity, the frequency of these habits. The intensity and the frequency of these habits will determine how much amount of malocclusion is going to happen. With a high intensity and uh, high frequency, you can see a severe changes in the occlusion and the perioral structures. So if you see it, you are supposed to treat it at the beginning itself. The most common one is the thumb sucking or the digit sucking habit. It has enormous consequence on the maxillary arch. This sucking habit is quite common until 4 years of age, and we usually do not treat it till 3 plus years. But if the intensity is severe, if the frequency is high, we are going to intercept this habit at the earliest, because it is going to cause certain changes in the maxilla, mainly the open bite and also posterior crossbite. The crossbite is a result of the altered tongue posture, because the thumb is occupying the palate and the tongue is lowered in the oral cavity, and the patient is also exerting a negative pressure in the mouth, leading to a high buccinator mechanism that compresses the arch, and the thumb is pushing the maxillary anteriors more labial. So in turn, you will see this anterior open bite and a posterior cross bite, indicating that the habit is severe. And this open bite, if it is untreated, it can persist in the mixed dentition period too, and it can also hamper the growth of this maxilla, altering the aesthetics of the individual. So identifying this digit sucking at the earliest, and always intercepting it, treating it, and making sure it stops. Because sucking urge is quite a normal urge in the infants, but due to certain reasons, due to reasons of insecurity, a working mother, an absent mother with a child, the insecurity leads the patient to continue the urge of sucking even after 4 years of age, and it becomes a chronic habit. The severity of this habit can be checked by checking the fingers of the individual. You can see this on the thumb. This is known as the callus. This shows that the habit is too intense, too severe, and is being done for a quite long time during the day. And also, you can see a dishpan thumb, a clean thumb. That means this digit is being kept in the oral cavity for a longer period of time, and it is high time that we stop this habit at the earliest, because it is going to bring about a massive dentoalveolar change. A big malocclusion is in the making. A simple treatment is sufficient in the initiation, like using a thumb puppets to deviate the attention of the child, using a T bands or an elbow bands to prevent this habit. It should not be a punitive one. If the individual is not stopping this habit, even with these appliances, you go with the intraoral appliances. This habit breaking appliances are quite the best in controlling the habits, and they also aid in positioning the tongue in its normal position. So this tongue crib helps the tongue to be in the palatal vault, and this bluegrass appliance helps to deviate the mind of the patient. Instead of sucking, he just rolls these beads, and also this appliance helps in positioning of the tongue. So position of the tongue is more important here, because the malocclusion is a result of the aberrant tongue position. You can break the habit, but we should also train the tongue to be in its place. That is very, 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 very important. Most of the malocclusions in the oral cavity happens because of this misplaced tongue. The tongue is the only force inside the vault of the palate that keeps the equilibrium with the extraoral forces. That is mainly the lip, the perioral musculature, and the buccinator on the posteriors. So, with the absence of tongue in this palatal vault, these forces on the outside push these posterior teeth. They constrict the arch, reducing the intra-arch width or the intercanine width and the intermolar width. With this constriction of the maxilla, there develops the breathing problem also. The nasal cavity is also small, and the patient tends to breathe through the mouth more and more and more. So this palatal width should be optimal for the individual to comfortably breathe through the nose too, and also for the tongue to position itself in a normal vault on the palate. If you are just correcting the position of the tongue, the malocclusion or the growing malocclusion easily gets corrected, because the equilibrium between the outside and the inside is being established by this. So always do not ignore. You can use these simple appliances. You can just send an impression to the lab. They'll just fabricate it for you along with the molar plants, and you just cement it for a period of 6 months to 1 year. It takes 6 months to 1 year for the habit to be stopped, and also it takes 6 months for the habit to bring about any dentoalveolar changes in the arch. And also it should be done high frequently and also with severe intensity to bring about major changes in the heart. So these appliances should be placed in at least 6 months to 1 year in the oral cavity. And the tongue thrusting. Tongue thrusting does not cause malocclusion, rather, the existing malocclusion adapts the tongue into that empty space. Any open bite that is being present, any discrepancy in the occlusion, the posterior or the anterior spaces that are present, the tongue tends to position itself in that space. So closure of these spaces, correcting this malocclusion itself will position the tongue in the normal vault itself. So these appliances, the tongue clip or the bluegrass appliances, can also be used to train the tongue to position itself in the arch. And you should also correct the cause for this tongue thrusting. The major skeletal or the dental malocclusion should be corrected, and the tongue should be trained to position itself in the arch. There are various exercises that we train the patient in positioning this tongue behind the incisors, behind the incisive papilla. You can go through that exercises and teach the child to perform it at home. So these exercises, along with the correction of these occlusion, will help in correcting or preventing a major malocclusion in the future. So always evaluate the frequency of the habit, the duration, how long in a day is the patient performing this habit, and how intense it is. Lesser the intensity, lesser is the dentoalveolar changes. More the frequency, faster is the changes, and more the duration, severe is the malocclusion. So intervention to terminate the habit should be initiated at the earliest, and also parents should be involved in the treatment plan always. We should inform about the consequences this habit has if it persists beyond a particular age, and also the cooperation from the parents is very, very, very important, because all the appliances that you place, the patient might not wear it. So without the cooperation of the parents, you will be unable to eliminate this habit. That is why you should always show them the consequences. You should always show them, have the cases where the consequences have already happened, show them to the parents and tell this is what is going to happen. This should be prevented at the earliest, so that the dentition is going to proceed with normal development at a later point of time, and there will be no or very minimal orthodontic treatment that is required at a later point of time. And one more reasons common reasons for malocclusion is failing to maintain the space of the extracted tooth or the last tooth. Most of the general practitioners just extract the primary tooth because it could not be saved, but fail to maintain that space for the permanent tooth bulb. The best space maintainer is the natural tooth itself. The natural tooth and the root in the arch is the best space maintainer, and I always try to maintain that tooth in the arch, irrespective, even if the crown is not there. Even if the crown is not there, I always try to save the root at least with just placing a restoration, so that the root at least will guide the erupting tooth into its place till another 3 4 years, because most of the space maintenance which we place are fixed ones and they do not replace the function. So why not I just save the natural tooth itself, which has a good root, but there is a gross decay of the crown. So what happens if you just extract the tooth and you do not place a space maintainer? The worst happens in the first 6 months of age. The first 6 months you see rapid movement of the posterior tooth and the anterior tooth in the extracted space. At least 50% or 60% of the space is lost in the first 6 months itself. So in another 2 to 3 years or 4 years, we can see complete closure of the space for the permanent tooth, and you might see either the permanent tooth will be impacted or it might be buccally or lingually erupting in the arch. So this is the consequence. As you can see here, one of my case where you can see the primary molar is being extracted prematurely. You can see the distal migration of the anterior teeth and the mesial migration of the posterior teeth. This premature extraction or exfoliation worsens if it happens before the eruption of the permanent molar. If the molar has already erupted, there will be less force exerted by the molar. But during the eruption of this permanent first molar, maximum forces are being applied onto the second primary molar, because this second primary molar acts as a guide for this permanent molar to erupt in its place. So when it applies force onto this primary molar and no first primary molar, the forces is transmitted and the primary molar also moves mesial. And in the mesial segment, if the tooth is extracted before the eruption of the lateral incisor, the space loss is more, because these central and the lateral incisors have a tendency to erupt on the lingual aspect in the arch. They erupt lingual to the primary tooth and they make space and move forward with the help of the tongue. But with the already available space distally, instead of proclaiming more, they move more distal. They move more distal and occupy the space. This leads to a phenomenon known as collapse of the arch. These anterior teeth should proclaim more, move more labially, and increase the circumference of the arch. But here, rather than moving anteriorly or labially, they are moving more lingual. This leads to a collapse of the arch lingually and total loss of space. So now, in order to create space for this premolar, you're supposed to distalize the molar, you're supposed to distalize the second primary molar, visualize this. So that's a hard task to do. Instead, just after the extraction of this primary tooth, if there was a space maintainer present, it would have prevented this malocclusion from developing. This is one more case where the primary second molars were extracted, but a space maintainer was not placed at all. And also, you can see the premolar taking the space of the second primary molar, and also the permanent first molar has moved more mesial, utilizing all the space. Now, that space for this premolar is just 1 or 2 mm. Here it is less than 1 mm. So what do you do now? You're supposed to distalize the molars, visualize the molars, proclaim the anteriors, create space. And here too, the canine space is also reduced. There is no sufficient space for the canine tooth. So this is the consequence of not placing a space maintainer just during or after the extraction of the primary teeth. So it's the OPG of the same patient. You can see here that the mesial tilting of the mandibular molar on both the sides, whereas the premolar still in a developing stage is totally blocked out. So it takes another 4 to 5 years for this premolar to develop and erupt. By then, there would be no space at all. The premolar will be impacted inside the mandible only. So this consequence should not happen at all. That is why space maintenance are very, very important, and you should plan the space maintenance before you even extract the primary tooth. So there are various factors that you should consider before you fabricate a space maintainer. I am not going in detail into it. So this is the right time. What is the right time to place a space maintainer? It is just after the extraction of the primary tooth. So you can see a bleeding socket here. I had planned the extraction. Prior to the extraction, I had already fabricated a space maintainer. This is just a partially erupted permanent molar. So immediately after extraction, I just placed the space maintainer, and I am not giving a chance for this molar to even move a millimeter mesially. So this space maintainer program is difficult because tough for you to convince the patient for space maintenance program, because if it happens at this age, at least I need three space maintainers to complete this program. I need a reverse banded loop, I need later a banded loop, and later a lingual arch. So three space maintenance convincing the patient, the charges and everything is quite difficult, but I show them the consequence of not going for a space maintenance program. If this patient comes to me after 6 months without getting the space maintainer, almost half of the space would be closed by this erupting permanent molar, because there is no guide for this permanent molar. The second primary molar, which acts as a guide, has been removed, so it tends to move more mesial and mesial and takes away the space of this second premolar. Hence the planish is imminent. I have given the space maintainer immediately. The same patient who came to me after 3 to 4 years of age, after 3 years or 4 years after placement, you can see the premolar that is erupted at that space. The patient came to me, they saw that this premolar has been erupted, and I just removed the space maintainer, because the E space is still there, the leeway space is still there, there is still sufficient space, the D is still intact, the canine is still intact. This premolar can make its own space and erupt. This is one more case where I had placed a Nance palatal arch because there was bilateral loss of the primary second molars. So after 3 years, the patient came back with all set of permanent dentition. You can see both the premolars, both have sufficient spaces, both have erupted well in alignment. The Nance palatal arch still intact with no deformities, and it's 3 years since I placed it. The objective is being served by the space maintainer. This space maintainer can be just fabricated in the lab. You just have to take a impression, send it to the lab, and tell them the design. They'll fabricate it along with the molar bands. You just have to cement it and put the patient on a follow-up every 6 months. Every 6 months, you are going to check if the space maintainer is loose, is there any decalcification around it, or is it interfering with the normal eruption, and if any corrections needed, you are supposed to do it. And you can see the alignment of these incisors too, how well it is aligned. I just prevented these molars from mesial migration. So this arch length is being maintained, and all the teeth have utilized that leeway space and erupted into its place. So there are various designs in these space maintainers, and various options are available. And these are all the success stories of the space maintainers. You can see the premolars being erupted, the space maintainer still intact. The patient has come back. The patient has come back on time just when it is erupting. That means the patients are very well knowledge about this program. So it's not a difficult program to start with these patients. You just have to tell them the consequences, the advantages, the benefits of the space maintenance program, and how it reduces the complexity of the fixed orthodontic treatment in future. So you should also make the patients understand that this space maintenance program is not the sole thing in correcting malocclusions. Rather, it just maintains the space for the erupting premolar. Most of the patients think that just by placing the space maintenance, I'm going to align all the tooth in the arch and there will be no malocclusion at all. So that thing should be cleared in the very beginning itself. This space maintenance is just meant to maintain the space and not meant for correction of any of the existing or future malocclusions. But maintaining the space prevents the loss of arch length, and it reduces the severity or complexity of the fixed orthodontic treatment in the future. And if in the mandible, this appliance known as the lingual arch space maintainer is a wonderful space maintainer. Any issues with the space, you are supposed to just place this lingual arch, because this appliance is so good in maintaining the arch length. It prevents the mesial migration of the molars. It prevents the lingual collapse of the anterior teeth, maintains the leeway space, and allows the premolars to erupt in its place. This can be worn for multiple years because it's not going to take any support of the primary teeth. It just rests on the permanent teeth, that's your central and lateral incisors, and it's been banded onto the permanent molar. So it can be given from 8 to 9 years of age after the erection of lateral incisors, and it can be continued until 12 to 13 years of age until all the teeth erupt into its place. So always consider any discrepancy in the lower arch. Always go for a lingual arch space maintainer after the centrals and laterals have completely erupted. This prevents loss of the arch length. Gaining arch length is very difficult. So if we pediatric dentists maintain this arch length, it is very easy for the orthodontist to just align the tooth, derotate or align or change the inclination of the tooth, because it comes with a less relapse in the future. And also, any missing tooth or prematurely lost tooth in the anterior tooth should always be replaced. If it's a single tooth or a multiple tooth, it should always be replaced because it brings uh, aesthetics back, it brings about the function back, and it brings about the confidence back. And if it's a multiple tooth, definitely you're going to replace it because it prevents development of any aberrant habits, especially the tongue. The tongue position will be altered if there are multiple tooth loss. It hampers the speech development, and also there is no good aesthetics if the anterior tooth is lost. So if you just replace it with a simple appliance, just like an affixed RPD, okay, it's just bonded onto the tooth with a molar band and extended arch, whereas like a palatal palatal arch incorporate into this acrylic RPD. So it can stay for years, and you're supposed to check every year regarding the development of the arch. If it is too tight, you can replace it with a new appliance, but you should never stop by telling anyway the teeth is going to come at 8 years. Why do you require such an appliance? It's difficult for the patient to wear. No, it does wonders after you place. You can see the confidence in the patient by checking their looks. They are so happy. They do come back for a follow up at a later point of time by themselves because they are very happy with the treatment. Never leave the extracted tooth just like that because it leads to collapse of this upper lip, leads to the lower position of the tongue, it leads to retained infantile swallow. With such one simple appliance, you can prevent all these, and you can prevent a developing malocclusion before it even begins. And in a mixed dentition period, you're supposed to see whether early or limited orthodontic treatment is needed. So when it should be done, who should do it? Either you can do it, you're eligible to do it, you know what to do, or you need a referral to a specialist. You call a specialist, either a pediatric dentist or a orthodontist, because some things might be complex and just mild corrections would not correct it totally. So there is something known as orthodontic triage, where you can distinguish moderate from complex treatment problems. If you're not well versed in treating moderate or complex treatment problems, I insist always take a pediatric dentist or a orthodontist and make it a team work, and you can see the changes in the developing dentition. So if you see a moderate or a severe problem like unusual facial appearance or a craniofacial deformity or any existing syndrome or any complex medical treatments or any vertical or lateral jaw discrepancies, excessive protrusion, or a class 3 maxillary tendencies or retrusion of the incisors, you are supposed to make it a teamwork, take the help of a pediatric dentist or an orthodontist and plan a treatment plan. And you should never ever postpone these treatments telling that it can be done after 12 years or 13 years of age. We will do a fixed ortho after 13 years of age. Until then, it is okay, it is still developing. These are the most common reasons what I have heard from patients. Sir, that dentist had told me that we can do it after 13 years of age. That's why we could not come. By the age of 13, 14 years, it would have been more severe because the growth would have been the puberty would have already been initiated, any myofunctional appliances period would have been over, and more corrective treatment will be insisted during 14, 15, or 16 years of age. So the time limit would be 7, 8, 9 years for such treatment, where you can modify the growth, change the growth, alter the forces, and bring back normal growth trend in the maxilla and the mandible. So there is no age limit to postpone it to 13 or 14 years. I insist that you take the help of an orthodontist or a pediatric dentist, and always discuss the treatment plans and discuss it with the patient, and take a consent and start the treatment right away. Because as you live for more and more years, the development of the jaws will be worse. It might lead to a asymmetrical phase, it might lead to severe attrition, it might lead to development of habits, it might lead to bad aesthetics, and also there will be a jaw deviation. The patient will be eating on only on one side. There will be changes in the temporomandibular joints. So at 13 to 40 years, there will be lot of problems for the orthodontist to deal with. Growth modification or guiding the growth at a very early age of 8, 9, and 10 years helps immensely in the second part of the treatment, that is during the teenage. The complexity is very low, and the treatment becomes too simple, and there will be no relapse. And also, sometimes it would lead to surgical corrections of these, and the patient should live his whole life with the surgical deformity only. So this age is quite crucial, the mixed dentition period. But for you to do it, you are supposed to first diagnose it at the earliest. So any missing permanent tooth, any asymmetric sequence of pattern of the dental development, failure of erection of the teeth, ankylosed primary teeth, or any supernumerary teeth, any ectopic eruption or transposition of the tooth should always be considered for a detailed discussion. So any problems here, there are multiple options to be done during this period of mixed dentition. Either it might be a space maintenance program, or a space regaining program, or an arch expansion, or multiple tooth extraction, or bring about a bodily movement, or planning for a serial extraction. There are various treatment options available, but you are supposed to decide which treatment you are going to go ahead with. So diagnosing these orthodontic problems in the mixed dentition at the earliest, you can bring in interceptive orthodontics and prevent major malocclusions in the making. So you're supposed to check for the health of the teeth and the oral structures, the alignment and occlusal relationships of these teeth, and facial and the jaw proportions. So I'll be dealing with most common things what we see and what as a general practitioner you can directly treat with. The frenal attachment is one thing you should check for. Whenever you see a midline diastema, you should check for the maxillary frenal attachment. A simple tension just by pulling the lip outward and upward, you can see this attachment. If at all, if you see this attachment between the teeth, that is papilla penetrating, this attachment will be onto the incisive papilla. So this muscular attachment will prevent the normal closure of the incisors, leading to a persisting diastema in the midline. So you are supposed to treat it at the earliest, remove this muscle from between the two, and then go ahead with closure of this diastema, and this will be successful. Most of the times I have seen patients who have completed their orthodontic treatment but comes back with a relapse, telling I had a gap before the treatment. Once they stopped, again the gap increased. I checked this frenum, and the frenum is still being attached in this abnormal position. So releasing this will correct the occlusion, or else even after the treatment there will be a relapse. And also the lingual the lingual frenum also limits the movement of the tongue, because it will be attached to the tip of the tongue, or it will be attached to the mandibular incisors on the lingual aspect. if you encounter that, it is to be treated immediately, because any limit in the movement of the tongue will hamper the growth of the maxilla in its normal arch form. So even if it's a 1 year old or a 2 year old or a 3 year old, the lingual frenum, if it is abnormally attached in the arch, it should be released immediately. It helps in good positioning of the tongue. It helps in mature swallow development. It also helps in normal speech development. And one more thing we see in the mixed dentition period is abnormally erupting permanent molars, that is ectopically erupting permanent molars. This can be just diagnosed by seeing this type of eruption, where the mesial marginal ridge is not at all seen and it is just below the distal surface of your maxillary second primary molar. So this can be confirmed by just taking a intraoral periapical radiograph, where you can see that the distal root is totally resolved. The mesial surface is just beneath the distal surface of your primary second molar. So this should not be left behind, because it eats away the space of this second premolar, and also there will be a loss of arch length, and it should be treated immediately with simple appliances like a ligature wire or a Halterman's appliance, where you are just guiding the permanent molar more distally to erupt rather than resolve this primary second molar. So this can be initiated at the very earliest, and you should not wait for the permanent molar to erupt, because you are supposed to immediately guide it, change the angle of eruption of this permanent molar and save this primary second molar. If the distal root is totally resolved, it will be difficult for you to save this primary second molar. Rather, distalize this permanent molar and put a space maintainer to maintain the space for the second premolar. And also presence of supernumerary teeth. Mostly these supernumerary teeth in the primary dentition is being ignored, and the patient is being told later in the point of time when the permanent incisors erupt, these teeth will exfoliate on itself. According to me, this supernumerary tooth should be extracted immediately, even if it is seen in the primary dentition, because presence of this supernumerary teeth will hamper the development of these permanent incisors. They change the direction of the eruption of the permanent incisors, and at the age we can see that the supernumerary tooth still will persist, and also the permanent teeth has rotated and also is not in proper occlusion. So if at all, if you see a supernumerary teeth, just take a IOPR to rule out any more presence of supernumerary teeth in the arch, and always extract it immediately. That will guide the eruption of the permanent molar. And one more common scenes you see in the mixed dentition period is the over retained primary teeth. The permanent teeth has erupted, but the primary teeth has not shed at all, or sometimes the permanent teeth has not erupted at all. So if you see over retained primary teeth, always go for an intraoral radiograph. So this patient where I took a OPG revealed that there are multiple supernumerary teeth that are present. There were three supernumerary teeth present, and the permanent tooth struggling to erupt in the arch. So upon taking CT, there are multiple teeth, and we did the surgical treatment to remove the supernumerary teeth and put the patient on a follow-up to check the eruption of the permanent incisors. Within 1 or 2 months, the permanent central incisor started to move into the place. So at a later point of time, we'll see accordingly how much the tooth has moved, and we'll go for a fixed orthodontics, apply brackets with surgical exposure, and drag down the incisors into the arch. So any over retained tooth, always go for a radiograph. Always check why the permanent tooth has not erupted. And this is one more case of a pulpectomized primary molar, primary incisor. So there was an infection in the periapical region which had led to the change in the path of eruption of the central incisors, and you can see completely the incisor is palatally placed and this primary incisor still being intact. So immediately you should go for an extraction of this central incisor because this tooth is in crossbite. So such crossbite teeth will not allow the jaw to grow normally because they will hamper the growth of the maxilla because they get the maxilla locked into the mandible, and the crossbite should be corrected immediately without waiting for any more days. And these are multiple retained teeth in the arch, multiple decayed teeth, a total neglect of oral health by the parent. And you can see after extraction how neat it looks. The maintenance of such arch is quite easy than this arch where it's difficult because the patient find it's difficult to brush the tooth because there are multiple lesions in the arch. So the total extraction was done of all the retained teeth, and later this patient will go for a fixed orthodontics. But this was already too late. As soon as you see a over retained tooth, it should be extracted. The patient should be educated that even if it happens for the next tooth in line, the patient should be brought back and it should be extracted immediately. Immediate extractions will allow for the permanent tooth to restore to its original path of eruption, and the muscles, the extraoral and the tongue, will help the tooth to erupt in its normal position. This is the mandible. It was the same, multiple retained teeth in the maxilla and the mandible arch, and this will be followed up by fixed orthodontic treatment. And this is one more case where a dentist had extracted the lateral incisors to aid the eruption of the central incisors. Whenever you see a central incisor struggling to erupt, please do not extract the primary lateral incisor. Extracting the primary lateral incisor is a disaster because the central incisor will take up the space of the lateral incisors. Then the lateral incisors gets blocked out. In another year or so, you will see the lateral incisors present in the palatal aspect, whereas this central incisor continues to persist in this big diastema. So in the ugly duckling stage, it is quite common for the incisor to struggle to erupt, but with the eruption of the central and the lateral incisors, the arch width is going to increase by around 3 to 4 mm. With the increase in the arch width, then the inclination of the incisors more labial, the incisor liability comes into play and they themselves arrange in the arch. So please do not extract the lateral incisors to aid the alignment of the central incisor. So this is what happens if you just extract the lateral incisors to aid the eruption of the central incisors. You can see both the sides, the lateral incisors were extracted. You can see the permanent laterals being locked out on the palatal aspect. Now, if you want to just align them, it is not possible because there is no sufficient space for the lateral incisors. So we go ahead in expanding the arch by a slow maxillary expansion device. So in such cases, do not postpone the treatment telling it is can be done after 13 to 14 years. Rather, expand the arch now itself. Expanding the arch and just labializing this lateral incisors with the help of its Z spring will bring about normal development. In this case, the normal development is not possible because the laterals and the centrals are just holding the mandible together. Neither the maxilla can grow forward or the mandible can grow forward. It is just stopping the development of each other. So this is just a simple appliance. It's a removable appliance. It's a slow maxillary expansion device with a jack screw in the midline. We are going to expand the maxilla, increase the space, and then push these teeth more labial with the bite plane aiding in raising the bite. So it might take around 3 to 4 months or 5 months to stabilize the occlusion. But once these laterals come out of this cross bite, the normal arch form will prevail because of the musculature. The muscle will make sure the teeth gets aligned in the arch because of the forces being exerted from the intraoral and the extraoral sides. And this is one case wherein the primary canine was extracted. The primary canine was extracted because of the locked lateral incisors. So most of the dentists I have seen extracting the lateral incisors for eruption of the central incisors, extracting the canines for eruption of the lateral incisors. So this should never be done because the tongue will always push the erupting centrals or the laterals more labial and labial, and with the eruption of the centrals and laterals, the arch width increases on its own in a span of 2 to 3 years. So if you are seeing a rotated centrals, a rotated laterals, you should not jump into just extracting the canines, because extracting the canines at the age of 10 to 11 years, the canine gets blocked. Most of the times you can see these canines present more buccally. So do not extract the laterals or the canines just for the sake of aligning the centrals or laterals. And there is some patients who come with a missing permanent teeth. So here comes the dilemma: what to do with this primary tooth, whether to save it or to remove it. So this should be consulted with an orthodontist to decide whether to remove the teeth and to leave the permanent dentition to close the space available, or to preserve that primary teeth, and at a later point of time you can extract it and replace it with a prosthetic. So that is solely decided by the orthodontist based on the occlusion or the existing malocclusion or space is required for the alignment. And you should always decide early at the age, because if you just leave this primary molar, it might get submerged, it might not be in occlusion. That might lead to supra-eruption of the opposing tooth, leading to food lodgement in these pockets, difficult to maintain the hygiene, and also it can lead to ankylosis of this primary teeth, making it difficult to extract these at a later point of time. So always a consultation with the orthodontist is required. The orthodontist can check the occlusion, the jaws, and decide whether this should be maintained or it should be removed. And at a later point of time you can always go ahead, in some cases where the permanent teeth are missing, you can go ahead and just close the arch off, closing the arch off, and you can modify it prosthetically to make it more aesthetically pleasing. And also some cases of missing teeth, you may see that the permanent teeth are malposed inside the alveolus because of the trauma, because of the trauma to the primary teeth or infection in the periapical region of the primary teeth. That's why in the beginning itself I said any infection in the periapical region, in the anterior region, will always lead to ectopically erupting permanent teeth. So the first step in preventing a developing malocclusion begins on the day the tooth is erupted into the oral cavity, to prevent any cavity or lesions in the tooth that will go ahead and destroy the entire tooth. So tooth size, arch length discrepancy and crowding, if it's seen, the treatment is mainly based on how much amount of space is being required by the arch to align itself. So if it is 2 or less space that is required, we can just wait and watch and do not do anything, because the developing arch increases the intercanine width to increase the arch circumference, and they themselves can align themselves. And if the space is just 3 to 4 and you can see a lower incisor crowding, you can disc the primary dentition, adjacent primary dentition or the permanent dentition, just to make it align, because the space available required is quite less, that is just 3 to 4 If the crowding and the space required is 5 to 9 you can extract that selected teeth. This procedure is known as serial extraction, and it should be done with the help of an orthodontist. It's a planning for around 3 to 4 years, and this serial extraction is not done at once. It is started at 8 years and goes until 11 years. There are three teeth that are extracted here. There is a canine, the first primary molar, and the first premolar. But it should be started at the age of 8 to 9 years, and it's not done at 10 to 11 years of age. And if it is more than 10 that is being required, a fixed orthodontic therapy is very much required in the patient. So based on the space needed, there are various treatment options available. So if at all, if you see arch length on the tooth size discrepancy, always it should be a teamwork. Consult with the orthodontist and see. Please do not wait until 13 years of age. This malocclusion should be reduced in severity in the mixed dentition period itself, because the corrective orthodontics always leads to a relapse. It is more complex and it more time taking, and most commonly severe malocclusions, the orthodontist always goes for a extraction of the premolars. So this can be prevented by the interceptive and the preventive orthodontics during the early mixed dentition, late mixed dentition itself. So crossbites are also quite common, where you see a malpost anteriors. Most commonly seen is the central incisors in the maxilla, either single or both the incisors being malpost on the lingual aspect. This malocclusion, that the crossbite should be corrected immediately and should not be left to be corrected at a later point of time, because this hampers the normal occlusion of the teeth. So this can be corrected by very simple appliances like a jackscrew or a Z spring. It's a removable appliance with the posterior bite plane. The posterior bite plane raises the bite, and the Z spring or the jackscrew just pushes the teeth labial. And this treatment can be completed within 2 to 3 weeks. Just with 3 to 4 activations, you can just push this central incisor anteriorly. Here we are not going to align the teeth. It is still in a developing state. We are just releasing this central incisors from the crossbite. Rest everything is taken care by the dentition itself. The developing dentition itself will take care of itself. You don't need to align them at all. Just by releasing this tooth. If you follow this patient up after 6 to 7 months, you can see a beautiful alignment of these teeth in the arch. You don't need to do anything extra. It's just a simple removable device fabricated in the lab. You just have to tell which teeth is the problem, and they just fabricate this appliance. So any developing crossbite should be corrected just with a tongue blade therapy. This tongue blade therapy can be initiated at home itself, but you are supposed to identify it at the very beginning. If you just see like this, an erupting incisor, just erupted 1 mm or 1.5 mm of eruption with no crossbites totally established, always insist on a tongue blade therapy. Teach the child to place this stick in between the lip and the lingual surface of the upper incisors, and to just bite at least 4 to 5 times a day for 5 minutes. Within a week, you can see a total correction of the cross bite. You do not give any kind of appliances here. It is done totally at home, because it is just erupting and developing at that period. But it should be diagnosed immediately. Do not postpone until the tooth completely erupts. Don't tell the patient, let it erupt still more, we'll bring in an appliance. It can be just corrected with this tongue blade therapy in the initial period itself. And also multiple teeth cross bites. This prevents the maxillary development. It prevents the labial placement of the maxilla. It prevents the downward and forward growth of the maxilla, and also it assists in a lateral deviation of the jaw. The patient is not comfortable biting, and also it prevents excessive trauma to these lower incisors, more labial placement, gingival recession. So a simple appliance, a removable appliance with Z spring is sufficient to correct these cross bites. So never ever postpone this, telling that it can be done on 12 to 13 years of age. A simple appliance can be given by you yourself itself with activation once or twice a week. This appliance should be worn continuously throughout the day, even for having their food, because once the patient removes it and just clenches, the occlusal forces push these teeth back to their normal places. So any posterior crossbite brings out severe changes in the facial profiles and facial symmetry. It doesn't stop here, it progresses onto the permanent dentition too. So whenever you see a crossbite, a segmental posterior bilateral or unilateral crossbite, you are supposed to correct it immediately and not wait, because it can lead to deviation of the mandible. The mandible always tries to place its occlusion in a comfortable position. So whichever side is comfortable, the patient tends to move his jaw either to the right or to the left. So this crossbite should be corrected immediately by various appliances. There are various appliances that are present, either a slow maxillary expansion or a rapid maxillary expansion. In the mixed dentition period, we usually choose this slow maxillary expansion devices, and if the patient is more than 12 to 13 years of age, we go for this rapid maxillary expansion devices. So this slow expansion devices, you can place it a bonded or a removable one can also be given. We are trying to expand the arch. Expansion of these arches brings about a total change in the maxillary arch, total change in the development, improves the airway, prevents mouth breathing, aligns the tooth very well, gives more circumference, gives more space for the teeth to align itself. So it can be a double arch appliance or a quad helix appliance. It's just fabricated in the lab. All you have to do is diagnose, fabricate a treatment plan, send it to the lab. They send you the appliance. You just have to cement it and activate it periodically. Never ever postpone it to a teenage age. Always do it early in the mixed dentition period itself, because the occlusion can be changed during the developing phase itself easily than trying to bend it during the later stages of ending stages of the growth. The 8 7 8 9 10 years of age is the mixed dentition period, where you can bring about various changes with less amount of forces, and the muscles adapt very well after the treatment, that you forget that you had treated this patient, seeing the changes that have been happened at a later point of time. Such is the beauty of these interceptive orthodontics at a very early age, and you are just supposed to identify them. It is very easy to convince the patients because of aesthetics. If it is aesthetics, the patients agree very soon. If you tell anything else, pulpectomy, crowns, or anything, they are least agreeable. But when it comes to aesthetics, the patients agree very soon, and it's easy for them to convince at this very late period. Even if you tell we'll do it after 13 years, they get convinced. Why to do it after 13 years when you can correct it at the early or the late mixed dentition period itself with simple appliances, where the complexity is very less, and the changes that is being adapted by the oral cavity is too good, and the success rates are very high. So I end by saying diagnosing and correcting malocclusions should be made at a very early period of time. And according to me, dental caries is one of the most common causes for developing malocclusion that starts at the very first year of life. If you want to prevent a developing malocclusion, you are supposed to prevent the teeth from decaying. You're supposed to save the teeth from decaying, and that leads to a normal maintenance of the arch form, prevention of aberrant habits, and prevention of multiple diseases that happens of these dental caries. And later, always identify and always decide whether you can treat it, or whether you need assistance of a pediatric dentist or an orthodontist, and come to a treatment plan, explain to the patient, and do it as early as possible, and or explain the patient the consequences of not getting it done today. What are the complexities present when you go for a corrective orthodontist at a later point of time? Tell, if you get it done today, the simplicity of the orthodontic treatment or the finish what you get at a later point of time is wonderful with very less relapse. Thank you.
Sir, can we take up a few questions, sir?
Yeah, let's see.
Sir, one doctor is asking that uh,
Okay.
after SDF application, can we do
Yes.
GIC or any restoration over that?
First and foremost, if you can do a GIC restoration, why do you want to do an SDF?
Yes.
SDF is usually done when the patient is totally uncooperative. So we put an SDF, we arrest the caries, and we go in for a follow up and then do the restoration. But if you want to do it immediately, you can do it, but that discolors the tooth. It's not a total contraindication. You can still do it. But my this thing is, why you want to put an SDF when you're able to do a glass enamel restoration directly?
Okay. One more doctor has asked that a single tooth crossbite can be treated in mixed dentition. I think sir has already answered for that in crossbite correction.
Yes, single tooth crossbite should be corrected immediately. It just take 3 to 4 weeks with a single Z spring itself, and with a posterior biplane. It just take 3 to 4 weeks, and it should be corrected in a mixed tension. It should not be left to the permanent dentition period.
Okay. Sir, pit and fissure sealant applications done, I mean, that application has done on the permanent molars in teenage kids or patients. Will it not cause any TMJ problems further?
See, pit and fissure sealant is applied just in the fissures. It is just applied in the fissures, and it should not come under occlusion. If you apply the pit and fissures just like a restoration, covering up the entire fossa, it just breaks down within a day because it comes under occlusion. It should be just like a thread. It should just cover the fissures. It should not be built up on the fossa. It should never come under the occlusion. It stays for at least 4 to 5 years. It only fractures, it only troubles the TMJ only if you have raised the bite. That means you have put lot and lot of material on the occlusion surface.
Exactly. Thank you, sir. Thank you so much. And it was a wonderful session. We all were really keen on to the points what you are presenting to us. It was so much informative session. Thank you once again. And I would like to thank all the participants who were there till now for your time and patience. Once again, thank you, everyone.